Right. I should have learned this lesson a long time ago. I feel really fortunate to work. My name is Travis Nichols, coordinator for Region 9 Healthcare Coalition, for those of you who haven't met. But I feel really fortunate to work with some amazing individuals. And and so we pack in all these great ideas, these presentations, and in these meetings, they kind of feel rushed because there's so much great work being done. But these presentations leading up to this made me realize just like how many people, by a show of hands, appreciate the work that was shared today. Because I just want to take a photo of everybody. Awesome. Thank you. And how many of you, by a continued show of hands, appreciate sharing information when it's appropriate during incidents like this? We heard it from Jessica, we heard it from Gail, we heard it from Ken. Thank you. And that's what I'm here to talk about real quickly. Many of you might have seen a presentation on this process in September of 2016. And what I'm hoping to do today is do a quick follow-up on how our region within the healthcare sector has developed a process to share information and get some quality, essential elements out there to develop a common situational awareness or common operating picture. So this was a process that was started in 2015 by many members that were in this room. It was a committee with some familiar names. And a real call out momentarily here, Elena Mira and Ryan Trailer, former Healthcare Coalition employees, were instrumental in completing this process and getting us to the point where we could roll this project out in a timely fashion in January and respond appropriately to get information out to the healthcare sector, which is what I'm hoping to kind of review today. But by show of hands, how many people are familiar with this EEI process? And switching hands, who has never seen this before? Brilliant. So this concept is pretty simple. What we're doing as a baseline to any response is understanding what the impacts are to the system, understanding where there are gaps and where there are needs and how we can start to address this by understanding what the problem is. So incident occurs, the Healthcare Coalition requests information from partners. We send out currently the plan is to send out a document by email to a distribution list of affected parties. We'll take that information and within a 2-hour window, partners get that information back to us by email. We'll compile that information into a situational report. That report outlines who's impacted, who's delivering services, who's not, where there's shortages of supplies, resources, or staff, or whatever the case may be depending on the hazard. And then that situational report is distributed back out to healthcare partners, emergency managers, public health professionals, state leaders, et cetera. And from that, that SITREP is shared within your agencies to understand where the impacts are and how things might start to affect you. This process was started back in 2015 after we had an Ebola outbreak situation, but it was actually the influenza season of 2015 when our public health officer here in Spokane County came and asked, what's going on in our hospitals right now? And we had a really high influenza season, and that kicked off a realization that we didn't have a systematic way to assess the impact of the healthcare. We had anecdotes, we had stories, but we didn't have a collective single point that could aggregate information across disciplines and really understand who needed assistance and where we could start to share resources. So this process of sharing information creates these products that you may have seen if you're familiar with it, but if you're not, this is the information form that we send out. This is the dashboard that's created and redistributed out to people, and then detailed information about the specific impacts. Before I continue, questions. It's a pretty simple in concept, but getting to this point didn't come from nowhere. It came from several events, whether it was wildfire 2015, windstorm 2015, and then most recently exercised in January 2017 for influenza. Questions about the process or how it's outlined to work. So we did this in 2017, and the state of Washington experienced an incredibly above normal influenza season that activated medical surge plans and postponed elective surgeries on the west side of Washington state. We were at capacity, and then we had a season that pushed us over the limit in certain counties of our state. And it created a situation where even moving 3 patients in Western Washington suddenly required significant coordination, activating their DMCC potentially to try and place patients. It was a completely abnormal situation where people were exploring 1135 CMS waivers. People were looking for altered acceptable care standards from HSQA at DOH. And so we realized that a single incident, whether it was one rally or whatever the incident may be on the west side of the state, could instantly fill patients here in eastern Washington. So that triggered us to activate the essential elements information process that we sent out. in response to the influenza epidemic that was declared by DOH on January 5th. I hope this like wordy slide with pointers is working for everybody. Not expected to read it. So we went ahead and updated our questions based on information from our public health professionals in the region, and then went ahead and gathered information and sent it out. And we continually updated the information that was gathered throughout the process and the frequency of the products going out and how that whole system worked. But it was still a pretty manual process, and we learned some interesting things. This was triggered by the call that happened from WSHA on, I think, the 4th or 5th. And then one of the key things that we had right out of the gates, we had executives from some of our hospitals calling to check in and say, where do we need to go? How do we start to get in front of this? And how do we start to respond to this? And are there impacts in our region? And that triggered the Healthcare Coalition to activate. And in our planning, this could be triggered by anybody. That question of what are the impacts and how do we start going, that can come from public health, emergency management, any sector of healthcare, and something that can be implemented pretty quickly if it's done right. So we also set ourselves up for a trigger to demobilize the process when no one had any known gaps or challenges, and when our influenza curve in Spokane County as an indicator county started to decline. So we knew we wouldn't see more impact throughout this area. So we sent 11 sit reps during this time period, and 20 agencies contributed, and almost all of our hospitals in the region participated. And these are a few quotes we received, and many of you either took a survey or provided some of these quotes through some of our after-action review processes. And I think the takeaway for us is that the concept that committee started with in 2015 and developed through 2016 was absolutely spot on. There is a demand for this. This has improved communication within facilities and between facilities. And the feedback we received is very much, you're on the right track. Let's just figure out how to do it more consistently and more efficiently and more effectively. Let's face it, you did this presentation in September. I didn't see you here. So a few things that we're working on improving in the back end. One is, this is a very labor-intensive process, very manual in the way we're implementing it right now. So looking at how we can make this more effective on the back end of the process for the aggregation component, automating some of that. If we can increase the amount of epi information coming into our respiratory panels that we're distributing back out to get more of a census rather than a survey of the information we're sharing back out from our public health partners, that's one of the things we're investigating and looking into. We're definitely hoping to work with some of those executives that called in early and put together some form of an executive leadership council or a committee that can quickly pull together some form of a command and control from the very highest levels to be in front of these incidents and start to give us some just real scope as we start to work into these larger incidents and processes. So that's something we're exploring to develop. And here we definitely had work around distribution and how we were going to get information back out to people, but not having an updated comprehensive list, and then there's always new parties identified who would benefit from this information that we'll be adding. The format didn't work for everybody. What was primarily influenced by hospitals with influence from other sectors is something that will probably become more balanced over time as the more providers from different disciplines participate in this process going forward. And then finally, moving outside of the very email-focused, very Word and PDF-focused process to something more digital that would allow for on-the-fly mobile input and other digital processes is something we're working on. So anything I missed from people in the audience that you guys were part of this process that got us to this? The main message of today is if you're not familiar with this EEI process, we're working on improving it, but there's no reason not to participate today. As Ed mentioned earlier, every healthcare provider submitting 3 names that we can reach out to and contact to gather information from. We have a training video that's pretty darn good, if I say so, because this isn't the most difficult process. It's just making sure it's part of your organization's expectations and part of something that you're participating in when you're cubed to do so. And then from that, being a beneficiary of the information shared back out so we can understand the impact. Questions about the process or what we're working on to make it better for the future?